So today we've got Professor Tim Driscoll. He's going to talk to us about those very issues. He's a Professor of Epidemiology and Occupational Medicine at the University of Sydney. He's really well credentialed to speak with us today on this topic. His main research area is the epidemiology of work-related injuries and diseases. He's worked for several years as a member of the team considering occupational risk factors in the World Health Organisation's Global Burden of Disease Comparative Risk Assessment, and most recently has authored the Deemed Disease Report, which we'll hear about today as well, so I won't give any more away about that. But please join me in welcoming Professor Tim Driscoll today.
Thanks, Melissa, and thank you very much for coming. I did speak at one of these quite a while ago, I think about 6 or 7 years ago, on a different topic. So if you happen to come to that talk, thanks for coming back, but it won't be the same talk. What I was asked to talk on is basically this topic, to give you a bit of an insight into work-related cancer, and I'm planning to give you a bit of a cook's tour through that. This is what I'm planning to cover. Just talk briefly about some relevant concepts, talk about cancer types and carcinogens, which are exposures that can cause cancer. I'm actually going to talk about deemed diseases before cancer clusters, so I'm going to talk a little bit about deemed diseases and just mention cancer clusters just because most of the time I talk on work-related cancer, people ask me about it, so I just want to mention it briefly. And then there'll be some time at the end for questions and comments. I probably won't go for 45 minutes, I think it'll be a bit less than that. And I should have said, I've got some photos in here to distract you. They're photos from my summer holiday. I've been going to the same place for about 15 or 16 or 17 years. So if you're bored with the talk, at least you can have a look at the photos. And I'll be going back there in about a month, so you can imagine what I'll be doing. And I forgot to say, that's my kayak. Mine's the one on the right. Okay, so just a few concepts in terms of work-related cancer and why perhaps it's not well appreciated in the community. So firstly, a lot of people in the community don't really have a good grasp of what sort of things can cause cancer, and so may not recognise that the particular exposures that they or people that they know have had might have resulted in a cancer or might result in a cancer. Most cancers that can be caused by work-related exposures can also be caused by non-work-related exposures. So people don't necessarily connect, if they have a particular type of cancer, they wouldn't necessarily connect it back to their work because there are non-work-related cancers or exposures that can cause it as well. And there's no way that you can tell if you have a particular type of cancer, there's no way you can tell for sure what caused it. I guess the one exception, or one of the few exceptions to that, might be if you had mesothelioma, you can be almost certain that that arose from asbestos exposure, but you wouldn't necessarily know where that exposure was from. And if you had lung cancer, for example, you could take tissue from it and look at it, but there's no way you could tell what exposure caused that. For most types of cancers, there's a long period of time called the latency period between when you're first exposed and when you develop the condition enough to be diagnosed with it. And for most cancers, that period of time, that latency period is, well, you'd say it's a minimum of 5, but it's more commonly 10 or 15 or 20 or 25 or 30 or 40 or sometimes even 50 years. So typically it's going to be in that 15 to 25 or 30 year range. And so it's very hard to pin a particular exposure down to a particular cancer, or if you have the cancer, to look back and think, well, what exposures might have resulted in that. And as sort of an extension of that, cancer is unfortunately a common disease, but it's particularly more common as you get older. And so most people who have work-related cancers develop those cancers in the late stages of their work or after they've retired. So again, they don't necessarily connect it back to their work. So first I want to look at, well, is it a problem worth thinking about it or not? Because some people, I think, would say, well, it's not that big a deal. Maybe it used to be a problem in the past, not anymore. What I'm going to show you initially is some information from the Global Burden of Disease study, which Melissa mentioned that I'd been working on. And this is hot off the press. I presented it as sort of draft information in June, and it will be published early next year. And what the Global Burden of Disease study is it's a huge study run out of the Institute of Health Metrics and Evaluation in University of Washington in Seattle, funded by the Gates Foundation, multi-million dollar study, none of which has come to me, I should say. So I'm a very small cog in that huge study. I run the occupational risk factors section of that. And what the Global Burden of Disease study is trying to do is to have an evidence-based approach to looking at, well, what is the burden of disease and injury? Not just work, but in general. What is the burden of disease and injury? What are the main illnesses? Who's affected? At what sort of age are they affected? How many people are affected? And also looking at the risk factors for those. So looking at, well, what are the exposures that are resulting in these diseases? So what you see here is, along the bottom, the various occupational risk factors that we looked at in this, and on the y-axis is the number of deaths, and it's in thousands. And I just want you to pay attention to this first one in green, which is the carcinogens. So the estimate from the Global Burden of Disease study is that there's about 300,000 deaths each year from people as a result of work-related cancers. So it's not a trivial thing. And you can see this is, compared to the others, it's the number one cause of work-related death across the world. This is looking at the types of cancer. And again, now you've got the numbers along the bottom, just to make it complicated for you. And not surprisingly, the number one cause of work-related cancer is lung cancer. So it's a very big cause of illness and death in the general community, but also in the work-related community as well. So over 250,000 deaths estimated per year. And that dominates the others. So I've just got a graph here that takes those out. So of the cancers we're looking at now, everything except lung cancer, and the big ones, mesothelioma, and larynx cancer down the bottom are about 5,000, and up the top is leukemia with about 2,500 or 3,000. But this one here is mesothelioma, estimated to be about 25,000 deaths per year. There's more than that of mesothelioma because some people get mesothelioma from asbestos exposure from not work-related areas. Okay, so that's looking at the world. This next bit's looking at Australia. And most of the information I'm going to give you initially is from a study that was run by Lynn Fritchie and that I had some involvement in, that was released, gee, that makes me feel old, almost 10 years ago. And really, it's the only study that gives a reasonable estimate of the number of cases. This is incident cases, not deaths. The number of cases of cancer each year coming from work-related exposures. And because of the way that you have to do this study, you can't go around just counting the number of cases. You have to use approaches that allow you to estimate it. So in a way, I perhaps should have made this 4,400 rather than 4,415 because I'm not claiming it's exactly that. But I want to give you a sense of the numbers. So about 4,400 male cases of cancer per year and about 600 or 700 female cases of work-related cancer per year. And for men, that's at about 10 or 11% of all incident cases per year, excluding non-melanoma skin cancer. So we analysed them separately. So there was an additional estimate of about 34,000 non-melanoma skin cancers. That was for 2006. It's not likely to have changed much, probably gone up a little bit since then, but not likely to have changed much. And I want to show you the type of cancers that are in there. I don't want you to concentrate too much on exactly what these numbers are, just get a figure for whether they're in the thousands or the hundreds or in the tens. And first we're looking at males, and these were the estimates for 2006. So the top three were lung cancer, prostate cancer, mesothelioma. Now there's a bit of controversy as to whether prostate cancer really arises from work-related exposures or not. Depends a bit on who you talk to. But using the particular assumptions that we used, we included the exposures that are thought to result in prostate cancer. So they're the top three. And these are the next five. So bladder cancer, colon cancer, leukemia, actually next four, and non-Hodgkin's lymphoma, and melanoma, stomach cancer and pancreas cancer. So all of those, you can see the lung cancer's 1,500 and all the rest are in the hundreds. So again, it's not a trivial number. So that's the number of cancers. And this is showing you, well, of those cancers, what proportion are they of all those types of cancers that occur in the community? And the thing to focus on initially that comes out is mesothelioma. What that's saying is that 90% approximately, and it depends on who you talk to, it might be as low as 80, it might be as high as maybe 95%, of mesothelioma that occurs in the community affecting males comes from occupational exposures, which is what you would expect. Some from domestic or para-occupational exposures as well, but the vast majority come from occupational exposures. What's perhaps a bit more surprising is you look at the estimate for lung cancer. I actually think that's a little bit high, and again, it depends on who you talk to and what exposures you include, but it's probably in the range of 15% as a minimum, and if you include other exposures up to 29-30%, of lung cancer cases in the community arising from occupational exposures. And you can see there's quite a few others that are in the teens. So again, it's not a trivial thing. So that's for men, this is for women. The numbers are a lot lower, and you didn't see breast cancer in there for men because the number of cases of breast cancer are much, much lower, of course, in men. And the numbers overall are much less, and that's because, by and large, women tend not to be doing the work that results in the exposures that produce cancer. But it's not like they're doing no work that results in those sort of exposures. So they're the number of cases, and this is the proportion. Again, you can see much lower than before, but not negligible by any means. So what we've looked at there is the burden of cancer. So how many cancers are occurring, what types of cancer. Now I'm looking at, well, what's causing it? What are the things that are resulting in the work-related cancers? We're back looking at the Global Burden of Disease study, and now, again, we've got the number of deaths, and along the bottom I've got the different exposures that we included in the Global Burden of Disease study. For various reasons, we couldn't include all of the exposures that say Lynn and I included in that study I've just shown you, because the data weren't necessarily available for all regions of the world. So we couldn't include everything we might have wanted to include. But certainly we're including plenty. And that should show you initially there's quite a few exposures that can result in work-related cancer. The next thing you should see from that is the dominance of asbestos in there. What we're looking at here, I should have mentioned perhaps earlier, is that if we're looking at work-related cancers now, this is reflecting exposure by and large in the past, and because of the latency, looking back 10, 15, 20, 30 plus years. And that's the case with asbestos, because if you go back 30 plus, or 40 years, so we're looking in the 70s and early 80s, there was a lot of asbestos being used in Australia, and a lot of people being exposed at that time. So that's what that is reflecting, not just in Australia but around the world. So asbestos dominates work-related cancer. Again, if I take it out, so this is just looking at non-asbestos exposures. And the big ones here are diesel exhaust, second-hand smoke, and silica. Now, big problems around the world still. And from an exposure point of view, there's still significant exposure from diesel, even though I'm saying this is reflecting exposures from 20 plus years ago, largely. Diesel is still a problem, diesel exhaust, sorry. Second-hand smoke is still a problem in a lot of regions in the world, and is still a problem for some occupations in Australia. And silica is still a big problem in many regions of the world. It depends on who you talk to as to whether silica is still a problem in Australia. There's not many people now who you would expect to get silicosis, which is not a cancer, but is a disease arising from silica exposure. But there's still a lot of people exposed to silica. So that gives you a feel for, well, what are the exposures that might be resulting in work-related cancer? Now we're looking at, pardon me, in terms of just looking at lung cancer. So this previous one was looking at all types of cancer. And I showed you earlier that lung cancer is the predominant type of cancer. So this is looking at, well, what exposures are resulting in lung cancer? And not surprisingly, asbestos is the number one. So asbestos causes mesothelioma, which is a cancer of the lining of body cavities, and it most commonly affects the lining of the chest, so it's around the lung, but it also occurs elsewhere, but it's different to lung cancer. So here we're looking at cancer of the lung itself, or lungs themselves. Asbestos is the number one cause of that. So again, if I take that away, well, actually I didn't take it away. If I don't take it away, I'll just show you some colours. Here's diesel, second-hand smoke, and silica. So they are the same big three exposures we saw before. And the reason they had the highest numbers is that lung cancer is the most common work-related cancer, and all three of them result in lung cancer. This is stepping slightly away from what I've shown you before. What I'm showing you here are the different regions of the world. The Global Burden of Disease study, part of the analyses divides the world into 21 regions and compares results between regions. What I'm showing you here is not just the number of deaths, but the deaths per million. So it's taking into account the population. Otherwise, regions, say, with China would just predominate. So here we're looking at deaths per population, and I'm only looking at asbestos-related cancers. Not all cancers, just asbestos-related, because I want to show you a couple of things. So those four regions in green are basically the richest regions of the world. So it's North America, Australasia, Western Europe, and Asia-Pacific, high-income areas. And they are the ones, you might think, well, that looks odd, but they are the ones with by far the highest per capita rates of asbestos-related cancer. And that's because they are the countries that were using asbestos 30, 40, 50 years ago. And so that legacy of asbestos use is coming through now, or still coming through. It's been coming through for a while. So there's Australia. We've got the highest per capita rate of asbestos-related cancers. And down here I've highlighted some areas in Asia. So East Asia, that's China. Southeast Asia, so that's sort of Vietnam. Central Asia, so Kyrgyzstan, those sort of areas. And South Asia, which is India. And their rates are not that high at the moment. But the problem is they are the places in the world where asbestos is being used now. And asbestos is being exported from a place, particularly from Russia, but from other places, and being used. And you can look at this and you know what's going to happen in these regions if that doesn't change. Because in 20 or 30 years, they are going to look exactly the same as this. And so I'm very keen, basically, on getting the message out that we need to do whatever we can to help these areas not use asbestos. And there are plenty of sensible reasons why they want to use asbestos, because it's a very good material. It's very good at what it does, and it's cheap. And there are countries like Russia that are wanting to sell their asbestos, and they're making it easy for those countries that perhaps don't have a lot of money, and so it's more expensive to get other building materials to use it. But we must work hard to find ways to help them not do that, because otherwise they're going to end up like us, and that shouldn't happen. It's bad enough that we made the mistake, but given that you can see what's going to happen, we don't want it to happen there as well. So that's looking at the world point of view. Now I want to look in Australia. And I don't know if it'd be a surprise to you or not, but actually there's very little information about carcinogens in Australia. And the only reason we have got some now is really through the efforts of Lynn Fritchie, who put together, Lynn worked at Curtin University, and she put together a team of people, including me, to try to get some information, try to get some evidence-based information on exposures to carcinogens. And it was done in a number of steps, and we're still doing some work on it. But it's been very useful in terms of allowing people to get a feel for, well, what are the important exposures and what proportion of people are being exposed? Because we really had no idea. So we looked, as part of that work, we looked at, well, what sort of things have been identified around the world that people might be exposed to at work that can cause cancer, and which of those are in Australia. And we identified just under 40 work-related carcinogens that there was good evidence to think that they are in Australia. Some a lot of people are exposed to, and some not many people are exposed to. And then there was a population-based survey conducted looking at what people did, asking them what their tasks were, and then there was an algorithm that would allow us to say, well, if you did this task, these are the sort of things that you would have actually done, and these are the sort of exposures you would have had. So we weren't asking people, were you exposed to asbestos? We were asking them, what did they do? And that's a much more accurate way of finding out what people might be exposed to. There's some estimate to it as well, of course. But if you ask people, are you exposed to chromium, are you exposed to nickel, are you exposed to whatever, most people don't know that. So, I should have said, so about 40% of Australian workers were exposed to at least one carcinogen. So again, it's not a trivial thing. Some of those people were exposed just a low level, but some at quite a concerning level. So I'm going to show you some of the information from that survey. This is initially looking at males, and then I'll show you females. And I just want to give you a feel for, well, what are the agents? So the agents are shown on the left, and what proportion of the Australian population are estimated to be exposed. Again, maybe I should have taken away that decimal point, because I couldn't say it was 28.6 or 29.3. It's just giving you a feel for the approximate level of it. So solar ultraviolet radiation, that's because a lot of people work outside. Diesel engine exhaust, because a lot of people work in or around diesel engines. Environmental tobacco smoke. Benzene, not so much, but still comes from fuel. Silica, lead. This is polycyclic aromatic hydrocarbons that occurs in burning off and fires, that sort of thing, and in cooking. Wood dust, shift work. There's a bit of controversy around shift work, but we included it as part of this. Artificial ultraviolet radiation, chromium and asbestos. So they were the top 12. And here are the percentages. So this is saying that about 5% of people, we estimate, still have some exposure to asbestos in part of their work. Not all the time, of course, but they do have some exposure, up to where about a third of people have exposure to solar UV radiation. And I don't want you to look at the detail of that, just to give you a feel. They are the top sort of jobs that were involved. And I've got another list of this later on. Don't worry, I know the writing's a bit small, I just want you to get a feel. There's a range of different jobs in which people have this exposure. So that was males, this is females. Similar sort of top 6, not exactly the same, not in the same order, and not exactly the same in 12, of the total 12. And there are a lot more, I just didn't include those. And look at the percentages, they're a lot less than males, consistent with what I showed you before in the Global Burden of Disease study. But again, not trivial. It's not like this is something that we should just not worry about. And they are some of the occupations. So I just have put all those occupations and got rid of the duplicates and put them on this slide. Again, not so you can memorise them all, but just have a look at that and think, well, have you done these jobs? Do people you know do these jobs? Do your relatives do these jobs? And if they do, it doesn't mean they are being exposed to carcinogens, but it means they've got a reasonable chance that they are, or they might have been, or they might be, if the appropriate controls are not put in place. So again, it's not just people working in a factory, it's not just people down a mine. There's a whole range of different occupations you can do that can lead you to being exposed. I just want to pause a little bit to talk about IARC. I presume a lot of you will know about this, but just in case you don't, I wanted to take you through it. IARC's the International Agency for Research on Cancer, and it's based in Lyon in France. And that's the organisation, and the people who work there are the group who basically look at all the information that's available and decide or give information on whether something causes cancer or not. Not just work-related cancer, for any. And they look at the evidence. They look at the evidence in humans, they look at the evidence in animals, they sometimes look at the evidence in cells, and on the basis of all that, they make a judgment. And they rate things as whether it's likely or not likely that they cause cancer. And they put them in different groups. And the first group are ones that are thought to definitely cause human cancer. So there's strong human evidence and usually strong animal evidence. So something like smoking causing lung cancer, asbestos causing mesothelioma, chromium-6 causing lung cancer. They're all group 1 agents. And then there are group 2A, and they're the ones where they're very suspicious, but there's a bit of doubt. So there's usually human evidence with a little doubt, so not enough to be sure, and strong animal evidence. Typically that's what happens to get something into a 2A. So you have to be very cautious about being exposed or controlling exposures in 2A, but we don't know for sure that they are carcinogens. And group 2B are ones where there's there's some evidence that maybe they cause cancer, but the evidence is not strong. There's group 3 where there's not enough information to decide one way or the other. And group 4 means it doesn't cause cancer. There's hardly anything in group 4 because IARC doesn't waste its time looking at things that you'd expect would not cause cancer. So I just want you to keep that in mind. Group 1, definitely causing cancer. Group 2A, we're pretty suspicious. Group 2B, there are reasons to be suspicious, but there's some concerns about the evidence. And I want to show you now some information I got when I looked at a study. It was a concern about cancer cluster at the National Gallery of Australia quite a while ago, almost 10 years ago. And when I started that investigation, I went in there thinking, well, there's not going to be a lot of carcinogens in somewhere like the National Gallery. It's just a place where they hang paintings and they do some restoration, but I wasn't expecting a lot. But we had a very good look in and around the gallery at what they used, what they used to do, and what was there. And we found all of those IARC Group 1 agents, we found those Group 2A agents, and we found those Group 2B agents. Now, the only reason I'm showing you that is just as another reinforcement to say carcinogens are not things that only occur in factories and down mines and in science labs. There's a lot of areas where, for a whole range of reasons, people are potentially exposed. Now, we felt in this study that even though all of these exposures were there, they were at a very low level and not enough to cause a problem, except for diesel exhaust for a particular reason, and that's been fixed up and not an issue. The other reason I wanted to mention diesel is that notice it's an IARC Group 2A there. It is now an IARC Group 1 because additional evidence has become available, and people have been suspicious for a long while that diesel exhaust caused lung cancer, but it was felt the level of evidence wasn't good enough. And IARC reviews the evidence as it becomes available, and so diesel is now classed as a Group 1. Diesel exhaust, is now classed as a Group 1 agent. That's another thing to say. Just because something is in Group 2A doesn't mean you should think, well, it's fine, because it's quite common that things get upgraded as more information comes to hand. It's rare that things get downgraded, but not uncommon that they get upgraded. And I think this is the last thing I was going to show you, to do with burden and exposures. Just to remind you of, I did show you before about the per capita rate of asbestos-related cancer in Australasia. And this is from the latest Australian Mesothelioma Register report, just released a couple of months ago. And it's showing you with the years along the bottom and the numbers along the side. So this is 1982 and this is 2014. And we'll come back to that, it's very important. Just to show you, the numbers have been going up, and they've gone from, about 100 to 150. Now they're about 700 or so. And you can see this has occurred over, 30 years? And what this is reflecting is exposures back in the 60s, 70s, to a lesser extent the 80s. We've probably got to the peak now, approximately, but there are going to be literally thousands, it'll probably more than 10,000 more cases of meso to come. Maybe not more than 10,000, but around there. So it's a terrible legacy. And as well as that, there'll be at least as many, and probably quite a few more, lung cancer cases that we just don't know about, because people get lung cancer, but we can't connect it to the asbestos so easily. Now, I've put this in partly because it's sedentary work that I haven't mentioned before, because it wasn't really looked at as part of the work we've done with Lynn Fritchie, and also not done as part of the global burden of disease. But it is going to be an increasing problem in terms of work-related cancers, I think, because we are increasingly sedentary. And it is being recognised, but there's still a lot of people who spend most of their day sitting down at a desk. And that is definitely not a good thing to do, not just from a cancer point of view, but including from a cancer point of view. I want to talk just briefly about deemed diseases. Again, I wasn't sure if I should mention this today, but discussing it with Terry and what you might be interested in, we thought it would be a useful thing. And I've recently been involved and done some work on this. So, I'll come to what deemed diseases are, but just as a little bit of background, the Cancer Council in WA, in fact, undertook a study looking at work-related compensation for occupational cancers, taking into account the work that Lynn and I did, suggesting there's probably about 5,000 incident cases of cancer a year related to work. But in terms of the number of cases that are compensated, so the ones that are recognised as being caused by occupational exposures, there's only about 400 a year. Now, there's a clear discrepancy there between 400 and 5,000. Now, maybe this 5,000 is slightly wrong, but it's not wrong by a factor of 10. And most of these are mesothelioma. So there's clearly an issue. There's a lot of people who are developing work-related cancer, and that's bad. We don't want that to happen. But if it does happen, people should be appropriately compensated. And that is not happening. And it's not happening for a range of reasons, some of which I've covered earlier. A lot of people have retired by the time they get the cancer, and they don't necessarily connect the cancer to their work. Often their doctors don't consider that the cancer might be work-related, or maybe they just consider it in passing and don't look at it. And it's not relevant really in terms of the management of the person, in terms of the medical management, although sometimes the compensation payments can help with that, of course. But whether the cancer came from work or not, you'd still want to treat it in the same way. Another thing is, even if the doctor recognises it or the worker recognises it or suspects it, it still has to go through the compensation system and has to be accepted. And that's a problem. The workers have to prove not only that they've been exposed to the relevant exposure, but they also have to prove that there is a proven connection between that exposure and the type of cancer that they have. And they have to do it each time. So often people aren't claiming, and even when they are claiming, it can be very difficult to get it through the system. And the deemed diseases approach is designed to try and help with that problem. So what the deemed diseases list is, it's a list of diseases, not just cancer, but I'm focusing on cancer here. So it's a list of cancers for which there's known to be work-related exposures that cause them. And if somebody develops that disease and they're known to have been exposed, it is assumed that that disease was caused by their work, unless there's some good reason to think differently. So the onus of proof is turned around, and it makes it much easier for people in that situation to be appropriately compensated. It doesn't make it easier for people who shouldn't be compensated to be compensated. And that's not the design of it. It's not designed to give people a freebie. What it's designed to do is to allow people who should be compensated to be compensated, to make it the whole system more efficient. It's easier for the worker, it's easier for the people running the system. So it's not every potentially compensable disease, it's not every potentially compensable cancer, but it's the ones where there's a very clear connection, and if the person has the relevant exposure at work, it's reasonable to assume that it's been caused by that work, unless there's something odd about it. So that's basically how it works. So, if the worker has the disorder, so let's say they have lung cancer, and they've had the relevant exposure at work, so let's say they've been exposed to nickel in a nickel refinery, then the disorder is assumed to have developed because of that exposure, unless there's a very good reason to think otherwise. So it can still be challenged, but the onus of proof is then on the employer or the compensation system, which is different to what it currently is. So the way the system currently works, the worker develops a disorder. If they think it might be related to work, they make a claim. And then the worker has to establish that there is a causal connection between that exposure and the thing that they have. And so I could do it, and then the next person coming along, they'll have to show it as well, and the next person coming along, they'll have to show it as well. as well as showing that they had to be exposed. Under the deemed diseases list, the first 3 steps, they're exactly the same. But the next one, it's accepted that there's a connection unless there's a good reason why not. The worker still has to show that they've been exposed, but the onus of proof is turned around in terms of the connection between that exposure and the cancer. And that just says the same thing, so I'll skip. So the key things there are the onus of proof is reversed. But to remember, the worker still has to show that they've been exposed. You can't just make it up and say, well, I think I was exposed one time. They do have to demonstrate that they were exposed. And if the disorder's not on the list, and not all cancers, for example, are on that list, it doesn't mean they can't make a claim. It just means that claim would go through the normal processes. Okay, finally, I just want to mention cancer clusters. A lot of people who are interested in cancer worry about cancer clusters. And I really want to mention it to say that most of the time that shouldn't happen. So people don't need to be concerned. But I want to reinforce that it should never be dismissed out of hand. And a lot of the high-profile cancer clusters you would have heard of, particularly, say, the ABC one in Brisbane, and you may not have heard of the National Gallery one, but this was pretty similar. The reason it became so high-profile, or they became so high-profile, was because they probably weren't dealt with that well early on. Not for any malicious reasons, just because people weren't sure what to do. That's my reading of it. But cancer clusters are not going to go away. I've spent the last 10 years trying to avoid being involved in any cancer clusters. And what I'm showing you here are all the ones that I have been involved in. So all of those, including one here and one up near Dampier, all of those I have been asked to get involved in, and I've tried not to get involved in, but I have. So cancer clusters are a recurrent concern in the community, and they're going to keep being a recurrent concern. These are the types of cancers that were involved in these cancer clusters. So you can see it's a range of them. And these are the settings. So again, it's not just a factory, it's not just down a mine. There's a whole range of settings where concerns come up. And when I give a talk on this, I have Driscoll's 4 important principles. I used to have 3, but I made up another one this year. And this is the 4th one that I'd like you to just think about, and if you are either concerned about it or if you are in an area where you need to talk to other people about the concerns, that nearly always, when there's concerns about a cancer cluster, when it's investigated, it turns out there wasn't a problem exposure there. But that doesn't mean you can dismiss it out of hand. If people are worried and it's dismissed out of hand, they will stay worried, and there's a problem there. And every now and then there might be an issue. So it should never be dismissed out of hand. But people should not be worried unreasonably. I think if there's concern about a cancer cluster, get some advice from somebody who deals with it. You can, not me. You can call me if you want, but I'm trying to avoid them, as I said. But get some advice. So don't ignore it, but don't lie awake at night worrying about it. Okay, so lastly, I've been presenting a lot of issues and problems. Now I just want to talk briefly about, well, what should you do? So the number one thing is I think you need to take the issue seriously. Don't dismiss it out of hand. If you're still working, then act to make sure that you are not being exposed, or if you are being exposed, that it's controlled as much as reasonably can happen. If you employ people, do the same thing. Don't let them be exposed. Make sure that you control exposures appropriately, and encourage all your relatives and your friends to do the same thing. And if you happen to develop cancer, you should have a think about it. Is it likely to have been related to work? I'm not trying to push people down the compensable pathway, and I don't want anybody to get cancer from their work, so I don't want to get to this stage. But I do want people to be appropriately compensated, and I do want the issue to be highlighted. Because if more people are claiming, or if the issue is raised, then employers and people running workplaces will recognise that there is a problem. And certainly if compensation payments are made, that's a good incentive to realise there's a problem and to do something about it. And finally, I'd just like to include this. I always do it slightly cautiously, but I think it's a good thing to keep in mind. Again, if you're here, you're probably here because you are concerned about cancer and what you can do to minimise your chances of getting cancer or getting cancer again, or if your friends or relatives getting it. So it's good to keep in mind, and I stole this list from Terry a while ago, and I've adapted it a little bit. But there are a lot of things that we know cause cancer and that you can do something about. Some are easier than others, and look, there are times when you can control them well and other times when it might just seem too hard. But it's just worthwhile keeping in mind there are things that you can do. And if you work on these 6, you'll go a long way towards controlling your risks of cancer as much as you can. So, in summary, the number one thing I'd like you to take away from this is just remember occupational cancer is not a trivial thing. It's not like only 1 or 2 people a year getting cancer. And it's not as though it's only a thing in the past, because people are still exposed, and a significant proportion of the workforce are still exposed to carcinogens in the course of their work. And what I'd like you to do is to act yourselves and encourage other people to act to minimise those exposures. And finally, if you do have cancer, just have a think about it. Might it be related to work? It's not going to change the treatment that you get, and shouldn't change it, but if there should be compensation payments coming, then they should be pursued. And that's it. Thank you very much.
We'll just get our roving mic ready for the questions. So if anyone has got any questions. Great, thank you.
Well done.
Thank you.
Now, I'm a worn-out old farmer, and what I see is, I think the bush, the central wheat belt, has I think the most suicides in Australia. But we're not even talking farm chemicals that go into the fruit and veggies and grain and meat and stuff like that. And when I find out about who regulates the chemicals that we put on the fruit and veggies and meat, and a lot of those can go in and last 6 months, so you can't wash them off, I find that the chemical companies are self-regulating. And the government only steps in when there's a big problem, and so often chemical companies are chemicals are being deleted. Now, one of the safest chemicals that we're using is Roundup, glyphosate, and then all of a sudden now I find out in some countries they're banned it because it's causing cancer, and it's meant to be one of our safer ones. If it's self-regulating, and every now and then the government steps in, and you find out what sort of gear that the government uses to take a look at the effects on animals or that, it's very antiquated. They can't afford the expensive stuff. So it's almost like it's a joke. I'll leave it to you.
Yeah, okay, that's a nasty first up question. I mean, really what you're talking about there is slightly different to what I've been presenting here. You're talking about potentially carcinogenic exposures that are going to get to the community, although farmers will have been applying them, so potentially exposed that way, for sure. So glyphosate, I'm pretty sure was labelled a 2A, wasn't it? Is that correct? Not a Group 1? Yeah, so there was a lot of controversy about it, but IARC had a very good look at the evidence. I wasn't involved in that at all, but I certainly trust their judgment on it. In the end, it's a judgment as to what rating a chemical is given by IARC. And so sometimes they even end up voting. So whether it should be at one level or another, sometimes you can argue, but I am suspicious of glyphosate and other similar chemicals as well. So I certainly think we need to be suspicious about them. In terms of the government regulation, look, it's not an area I work enough in to be able to talk sensibly about it. In general, Australia has a lot of self-regulation. It's not just in this area. There is a lot of self-regulation, and the government does only step in when it thinks the self-regulation isn't working. And it's not a perfect system. I agree it's not a perfect system, but I can't talk sensibly about this particular issue because I don't work closely enough with it. But just before I stop talking, because I don't like stopping talking, you mentioned you're a farmer, and you would have seen in those exposures, farmers came up a lot in those exposures. And there are still a lot of farmers and a lot of people working on the land, and that's certainly a big area where I think we do need to try and minimise occupational exposures.
We might be the canary in the cage because we're dropping like flies for what's going to happen later in public life. Like I used one chemical that was very popular with pigs, and it kills everything inside outside by slowing the metabolism down, and it was called Porec. And anyway, it got banned, but meanwhile my metabolism slowed right down. But nothing. How many other guys are like me? It's like you're saying. It's all single individual cases, and the government's not really got good enough gear to oversee it.
Yeah, so that's another good example that you need to try and minimise exposures as much as you can of everything that you can. And also, it is difficult dealing with individual cases. It's hard to see the problem as a whole, and that's why I think information like I've presented today, don't get hung up on the exact numbers because they are only estimates. But you just need to know, is it a big enough problem or not? And I think it's very clear it is a big problem, and so we need to put in control measures as best we can.
Thank you, Professor. You did a very, very interesting presentation. What I mean here, just in the beginning of your slides, you mentioned about some of the occupational cancer probably caused by related to the non-occupational exposure, something, right? So currently, a lot of people exposed to many chemicals, and like farmers or even us, not just maybe in occupational environment. So I think maybe we face some challenges on how to assess the multiple exposures to the chemicals or other hazard or carcinogens. And currently in the IARC, and the majority of the assessment on the carcinogens based on the single the chemicals and the exposure to these chemicals. So, how do you maybe have some ideas on assessment on the multiple exposure and joint effects?
I agree it's an issue. I don't have a good answer. What's more of a problem in my mind would be if you had two agents, neither of which cause cancer, but when they were if you're exposed to both, they could cause cancer. That's a difficult thing to work out. If you've got two agents that you know cause cancer, then all you're really trying to work out is, well, how much more of a problem is it if you get exposed to both? And I guess I would be saying if we knew they both cause cancer, we should be trying to minimise their exposures anyway. But I agree, there isn't good methodology for assessing risk for multiple exposures. I agree.
And probably also some of the non-carcinogens, if they come together, and do you think it could possibly can cause cancer, some of them?
I think it's possible, but I don't know of an example, so I couldn't say for sure, but I certainly wouldn't dismiss it out of hand.
Okay, thanks.
Thanks, Tim. Just a couple of questions regarding your experiences in interrogating and investigating cancer clusters.
I knew I shouldn't have mentioned it.
Because the quick slide that you showed, I think, of 13 or 14 sites that you've investigated.
Yep.
And you also showed a slide about the diversity of organisations.
Yep.
Am I correct in saying that there was a preponderance of white-collar kind of settings?
Yes.
Okay.
Yes. Although it's not only, definitely not only.
Definitely not only, but the majority.
So if I go through them, there were, I can think of at least 3 that were sort of industrial or clearly industrial settings. But there was one, for example, where it was an office environment, a very typical office environment, no suggestion, well, apart from one small thing, no suggestion of any carcinogenic exposures, but there were 3 women who developed breast cancer sitting at the same desk over 4 years.
That's not the Toowong experience?
No, not Toowong, because I didn't investigate Toowong. I know it pretty well, but I wasn't involved in that. And I had a very good look, and I was very confident there wasn't an issue, that it was just coincidence. But you can imagine why people in that situation would worry.
Yeah.
So that's, to me, a good example of why you should never dismiss it out of hand. Even though I didn't think there would be a problem, and I was confident at the end there was not a problem, the people who were there were very concerned that there might have been. And if it's not dealt with, if you don't sit down and explain the issues and look at it appropriately, people will remain concerned.
And you're able to make a couple of comments on Toowong, because the non-ABC media had us convinced that there was a cluster there. Yeah. Had the masses convinced anyway.
Yeah, I've actually got a whole presentation on the ABC one. So the ABC, there was no doubt the rate was very high in that group of women, but to condense my longest one into about 2 minutes, the problem is that in the community, there's an average rate of cancer, and that's made up of an average of lots of other rates of cancer. And cancer has a random component to it. There's no doubt there are risk factors that increase the risk of getting cancer, but there's a random component to it as well. And so just through chance, you will expect that there will be some places that have really high rates and some have really low rates, some workplaces, way higher than the average or way lower, just through chance, not because there's any problem there. And the ones that are really low, nobody worries about. But the ones that are really high, people look around and say, well, whoa, how come our rate's so high? And in the Toowong, it was probably 6 times higher than you would expect. And the question is, did that occur through chance, or did it occur because there was some problem there? And the only way you can sort that out is have a really good look at the workplace, which they did, and there was nothing found. And if you're still worried, the only thing you can do is to go elsewhere and look at similar workplaces and see, because the first place you've chosen because they had a high rate. If you go somewhere else with similar exposures and look at their rate, if their rate's normal, it's pretty likely that first one was just through chance. But if their rate is really high as well, then you'd need to start worrying. So what happened with Toowong is that after that, there was a different group who looked at the ABC offices around the country that had similar exposures, but weren't included in the first study. And that showed very clearly their rates were the same as the general community. And that, combined with the fact that there were no exposures found at Toowong, was very good evidence to say that there wasn't an issue. So I'm very confident that what happened at Toowong was a coincidence. I understand why people were very worried about it, and I think if the affected women were here, not all of them would agree with what I've just said, but I think what the final investigation was done very thoroughly, and as I said, I'm confident that it was a coincidence.
We'll just take one last question.
Thank you, Tim, for an interesting and a little bit scary talk. I've got a couple of questions about the deemed diseases list. The first one, what's the reaction from the judiciary about using this list?
Firstly, just to respond to your very first one, I didn't want to be scary. I just want you to be informed.
Yeah.
Because I don't think people should be scared when they go to work. If you work somewhere where there's asbestos fibres coming out, well, yeah, you be scared, don't go to that workplace. But the vast majority of people are not in that situation. You just need to be aware and alert so that when problems arise, they get fixed early.
My father worked in nickel mining for about 30 years, and it's not something I've really thought about before.
Yeah. So the judiciary, that they're not the issue. because normally it's not going to these through the compensation system.
Yeah.
It's not going to the courts until it's sort of got out of the compensation system. So I haven't had any reaction at all from them yet.
So my second question was, if, for example, you've got a farming chemical that you've got on that list as being a cause of an occupational cancer, so the compensation claim, who would it be against?
Okay, that's a separate system, or a separate aspect of it. And it would vary, I think, between jurisdictions from state to state. The deemed list doesn't deal with that at all. It wouldn't change it. That if it's an issue, and it is an issue, it's the same whether you go through the deemed diseases list or you go through the standard compensation. It's who would be responsible for that exposure.
Yeah, so you still need to find like the
Yeah.
manufacturer or someone like that.
Great. Look, I think we could just all join together and thank Tim for his presentation today. It's been very informative.